Welcome back and thank you for staying with KTN Prime. We continue with our conversation on the state of healthcare in this country, and joining me, of course, she's still here with me, CS Dr. Deborah Barasa. She's the CS Health Ministry in the country. So, of course, before we went for that particular break, we talked about this digitization system and what was in the Auditor General's report. So another thing that has caught Kenyans off guard and they're interested to know is whether their health data is protected.
Yes, I want to assure Kenyans that their health data is protected.
But it is in the hands of private entity.
It is protected, and we have involved the Data Protection Agency. And data is critical. Data, is when we have data-driven results, when we are looking at data, we are able to make, tangible decisions and get tangible results.
Okay.
For time immemorial, we've been having people, using paper, and now we are going paperless. And what that does is that we are able to identify or have disease surveillance. We are able to know what is the prevalence of the disease burden of certain communicable and non-communicable diseases. We are able even now to preposition to quantify commodities with regards to this, you see. So it has been a challenge, and that is what has led to corruption. We'll be able to guide even the governors, on what medications, what human resource for health, etc. that they need to have. It's going to be used even as an advocacy tool. Yeah. So what I want to encourage Kenyans is that let us embrace this, because this is the way to go. All the countries are going that way. The interoperability, the efficiency, effectiveness, transparency, and accountability, and that is really what I like, because with corruption, things are hidden in those papers. But when we have transparency and accountability, we always share this with even some of the private facilities and even public facilities. They're able to see.
But how assured are you?
Yes.
Because this is a private entity that has data of all Kenyans. How sure are you it's safe?
It is safe because we have passed it through the Data Protection Agency, and we are confident that our data is protected.
So then are you rubbishing the Auditor General's report?
Now, I'm not in a position to say that, but what I can assure you is that responses were given to all the concerns that she had raised, and what I can assure you, Ashley, is we'll have our PS to come and address all those things exhaustively.
What is our fallback plan now that we cannot even tweak the system? In the case where this system collapses, anything can happen. This is technology at the end of the day.
We are tweaking the system, actually.
How? Considering there was that clause in the contract that we cannot be able to.
So we are reviewing and, configuring and customizing it to our setting, all right? So that is what we are doing. Yeah.
Elaborate, because from that particular quote that I read just a few minutes ago, we are bound by a contract. We cannot tweak the system.
Okay, we are. And so what maybe what I'm saying is that PS Medical Services can come to discuss further. But whatever system comes, you need to customize it to meet what your country needs. Yeah, there could be language issues, the dates, the diseases. We need to customize the terminology. Our healthcare, like for the registers for facilities, again, we may use different codes with them. Okay, how we are using the names. We have other platforms like the ICHIs. So customization definitely occurs for any system that you're using. Yes.
Okay. Let's talk about the issue of contributions and ensuring that people register. What are the other means that we're using to lure in Kenyans, convincing? Because majority of Kenyans right now do not feel like SHA is the way to go. For those, should I say, the sheep that have been left behind, what are you doing to ensure that they are on board?
Yes. So it's critical that all Kenyans register. We need to really talk about that, and including the informal setting, because we see the formal setting are onboarding, but then informal, again, there's a bit of slowness. And so what we are doing is really working together with the community health promoters. So again, at county level, you know, implementation health is devolved. So the governors and the CEC, the teams for health within the county, and again, the community health promoters. And really, I must talk about the community health promoters. They have been able to visit 8.5 million homes out of the 12.5 million households in Kenya. And they've been able to diagnose more than 330 cases of diabetes and more than 331,000 cases of diabetes and more than 700,000 cases of hypertension. Equally being able to pick 134,000 mothers and taking them to facilities for care. And more than 6.9 children have been assessed under the community health program. So great work is ongoing. There's good coverage, and we are leveraging on this platform, that is the community health promoters, to ensure that they are informed, that they are assisting in a registry of patients, and also supporting them in order that they can contribute.
Okay. Now, according to the Project Consortium agreement, Apeiro will receive 57 billion shillings, Safaricom 21 billion shillings, and Convergence 17.2 billion shillings. Can you break it down for us? What exactly are their defined roles?
Okay. Now, that is an operational question, and it would go directly to the PS Medical Services, because each one of them was given a responsibility. Some of them were working on the SHA, e-claims portal, the SHA portal, and others were working on the registry, the health workers, and there was another team that was working on the patient journey. And so I apologize, I don't have those details, but given a chance, I can answer them.
Let's now talk about the funding cuts and how this has impacted Kenya in general and the health service. Now, of course, we're still reeling from USAID freeze. HIV mitigation programs, TB were some of those affected. How are we compensating for that as a country? And what is the extent of that implication of the aid freeze?
Yes, now I want to assure Kenyans that they are commodities at facility level. Tomorrow, Ashley, I hope you can join me. We're going to MEDS together with KEMRI colleagues and USG government representatives. And what we're going to do is, again, flag off medicines, flag off ARVs, anti-malarials, anti-TBs, among other medicines and commodities, so that they can reach facilities. And what I want to assure Kenyans is that for the next 8 to 9 months, we have medicines for Kenyans. Now, what are we doing thereafter? Because yes, they might continue lifting up, or again, they might pause. So as a ministry, we have sat in, and actually today we were with the development partners, sharing with them, seeing how they can support. Yesterday we were with the Council of Governors, together with the representatives from Treasury, and again the program officers and technical officers, and what the PS and the DG, and what we were discussing is how can governors implement. We have established, we've come up with a report, and in that report we are talking about the impact. We are talking about the resources that we need in matters human resource, in matters commodities. We actually even had, they had established a digital platform for various programs. So how do we integrate that into our digital health system, so that we have, integration and under one broader health system, which is Taifa Care. So those are discussions that are ongoing. We are sharing with Treasury. We have developed a CAB memo to share with the Cabinet. Again, for Treasury, we want to ensure that we are securing funds which will incorporate to support the commodities and also the programs that were being supported by USG. And what we are assuring Kenyans is we are working tirelessly, to ensure that we will not have a gap during this transition.
So this is within the 8 to 9 months, right?
8 to 9 months, we are comfortable.
Then afterwards, what happens?
Afterwards, that's where we are now securing funds from Treasury to support for the program to continue. But again, working towards integration of the program. What we are saying, we need one team, one plan, one budget, and one M&D. We've had fragmented, duplicated programs. Let me give you an example. Like for our HIV program, you have a truck with a driver. They come and take ARVs and they take to a facility. Then another truck with a driver takes anti-TBs and then takes to a facility. And another one, anti-malarials, to a facility. And these the partners are also in different counties. So you find that it's fragmented. But when we have it integrated and it's one, what does that mean? You can just have one truck and take all these medicines, all these commodities, and transport them, you see? So we have not had that, and that has led to inefficiencies. It has led to, it's not cost effective. It has led to loss of a lot of resources. And again, duplication, because anyway, a HIV patient can also have malaria, diabetes, TB. Does it mean that they go to another facility, you see? So it's all about integrating everything into one health system.
You did mention that it's a blessing in disguise. It's high time we depend on ourselves. But how possible is it? And it's all about effecting it and implementation. Because so many people say Kenya is not short of ideas. The problem is implementation. So when you look at the long-term plan, when it comes to ensuring that we can cater for our own health services, what does that look like?
Yeah, being a doctor and working in a HIV program for more than 10 years, I understand. And having worked for more than 10 years, I know we are over-dependent. We are over-dependent on donors when it comes to certain programs, yeah? And when the President, Donald Trump, had talked about self-reliance and self-sufficiency, that is a journey. And when countries, when you're talking to partners and you're talking about sustainability, self-reliance, self-sufficiency, then there is that synergy. They want to push you forward. So the discussion right now, deliberations are not about the over-dependence. It's about how do we support you to be self-reliant. So that's the journey we are taking. So there is no turning back.
There's no turning back. I know, was it 2 weeks ago, the Ministry of Health officials were supposed to meet the US ambassadors to try see if there's a way that we can get aid in a different, maybe directive, not basically from USAID, but find another way of us getting aid. How far is that particular process?
Yes, we are engaging development partners and other partners to see how they can support us, talking to governments, having G2G, private-public partnership, etc. But I'm still focusing on that. Self-reliance and self-sufficiency is where the way to go. So this is just a transition process, yeah? But ultimately, what we are seeing, donor funds are dwindling, right? Right now, the focus is really, when you look at the partners, it's not about HIV, it's about security.
Yeah.
That's what people are talking about, and humanitarian concerns. So since the tables are turning, then we need to anticipate for whatever comes our way. And so as a country, we also have to come up with solutions that are reliable and that are able to support our patients. So during this transition, even as we look for donors to support us during the transition, what we are really emphasizing from National Treasury is resources to support our patients. Yes.
So in general overview, how does this affect Taifa Care?
Now, Taifa Care is again the answer to all these programs.
How?
We've had multiple programs. So when you look at HIV program, it's the same thing. You go to a primary health care, you're given ARVs, and if you complicate, you go to the higher levels of care where you're admitted. Under the social health authority, the primary health care, we can have our ARVs under the primary health care fund, meaning each and every HIV patient can access those ARVs if you're positive, yeah, at no costs.
But we're currently rationing our ARVs. If
we are not rationing. We cannot ration ARVs. No, we can't. Yes. And we've had so much gains. I mean, we've had 98% of patients diagnosed, 98% treated, and 94% virologically suppressed. So great improvement in the HIV program. We don't want to lose the gains. So what we are emphasizing, we need those medicines at the primary healthcare level. Again, the challenge would be the human resource, but what we are looking at is the core human resource that we require to support in terms of management of cases, because that's a lot of knowledge that has been gained by these the staff that were working in the HIV program. So again, integrating them into the broader health system.
Okay.
Yes.
From a point of authority as the CS of health in this country, if you're told to define the state of healthcare, how would you define it?
First of all, I believe we're progressing well. When you look at the UHC, we've implemented the follows. We have implemented social health insurance with more than 20 million Kenyans, which is 3 times that which we had in NHIF, already registered, okay? They can access care, and they are getting affordable quality care. We've enhanced our cover to include other health benefit packages such as the ICU, oncology, mental health, among others. And again, we've improved accessibility and have complementary funds. We have the contribution through the Social Health Insurance Fund, but we have again National Treasury helping us with the Primary Healthcare Fund and the Emergency Chronic Critical Illness Fund. So a blend of resources that can support us at any time. Now look at again the amount that we have, 2.7 surplus, you see? Meaning that if we have all Kenyans on board, then we'll have enough finances to support in terms of expanding health infrastructure. We've enhanced our PHCs. Previously, we're encouraging level 5 and 6 under NHIF, and especially the private were the ones who are benefiting. And you see that a bit of noise is because of that. Now we are encouraging primary healthcare facilities. I remember even the governors one time when we were having a meeting, and they were saying, why is the private facilities having more money? And what we told them, now make sure that your public facilities get the same money, because once you're bringing your clients, the patients into your facility, they are registered, the resources will trickle down to the public facilities, and you'll be able to have human resource, commodities, equipment to support the people.
Okay.
Yes, again, there's a lot we've done.
Okay.
Yes.
So you have been at the ministry for what, around 5 months?
Yes.
How is the working relationship between different departments?
The working relationship is good.
Are you sure?
Yes, we are working well.
All right, I want us to just listen to something that happened just the other day at the National Assembly Health Committee. I believe we do have that particular bite, if we can play it.
It's not the first time we are not seeing the Director General here. In most of our meetings, he's not there. And what one would be expected is that there are technical issues where you may not even need to have all this. And our understanding that is the office that actually coordinates all these programs.
So why is it that the health DG, Dr. Patrick Amoth, is never there?
No, Dr. Patrick Amoth has to be there. And you see how...
But he's not been there.
Yes, now next time we will ensure that he's there. And he has the institutional memory, he has a lot of technical experience, and he is my technical advisor, So we are really relying on him in matters of advising us on the technical issues and bringing both state departments together, because you will notice that there are certain things that crossover. When we are rolling out UHC, some are in one state department, others are in the other, like primary health care and the community health promoters and in public health. And yet we have SHA, we have our digital health and other programs, the infrastructure, the NASPAR, under medical services. So the synergy, the harmony, the teamwork is really critical for UHC to be success.
Then one would assume, considering you're saying he's your technical person,
yes,
when it comes to such, an issue, when it comes to a committee, yes, he would be there to help you answer a few questions.
Yeah.
So what viewers are asking is, why hasn't he been there?
Now he'll be there. Next time you'll see him there.
finally, as we
Yes.
conclude, your parting shots, yes, as we conclude.
Yes, my parting shots, I want to assure all Kenyans, Taifa Care will be a success. We are very privileged and lucky to have His Excellency, our President, Dr. William Samoei Ruto. You know, he's the champion of Taifa Care. And we believe that once it is implemented, we'll have accessible, affordable, quality care for all Kenyans, no matter your age, no matter your tribe, whether you're rich or poor, you know, whether you're disabled. Each one of us should be able to access services whenever we need it. And so we are working tirelessly. People are, you know, people are ensuring that they are working to ensure that patients are able to access services. Yes, we have had challenges, but I can assure you, Ashley, right now the system challenges have really marvelously reduced. I talked to Lishenga recently and I told him, how is the system right now? Ask your people. And he told me that yes, we are doing well, the system has improved, and again, we just need to work on this and that.
How far are the claims?
The claims we are paying. So there was just a few of them that needed to undergo claims management for review. But most of the money we've been able to pay.
Okay.
Yeah. The only challenge is the facilities which have not given the right name and the right account number. So what we're encouraging the healthcare facilities, please review, see if your facility name is there, and if there is no money you've received so far, please reach out to our SHA team. We will work, we have the call center, we will work together to ensure that the money is released to you on time.
All right.
Yes.
Well, I do hope, as you've promised, that there will be a comprehensive report, and the PS will be coming next week,
Absolutely,
Thursday.
absolutely.
So we consider that booked.
Booked.
All right, thank you so much. That is Health CS Dr. Deborah Barasa. They're just telling us where we are at when it comes to the state of healthcare in this country. And that's how we wrap things up here on KTN Prime. Thank you so much for making time for us. On behalf of Jesse Rogers, Amerisha Wheaty, and I, have a good night.